This video is going to get you through chapter 25, which is the urinary system, sometimes known as the excretory system. Since you don't have the PDFs for this chapter, remember that you can pause this video at any point to make sure that your notes agree with what I'm telling you in the slides. Remember to highlight things or circle them so that you can, if you have questions about them, you can ask me about them the next time we meet for a conference within Schoology. Alright, so the first question in this chapter is, what do the kidneys do? Primarily what they're going to do is filter waste out of the bloodstream and then excrete it in the form of urine. In the process of doing that, it does help you regulate your water balance, your solute like sodium and potassium levels, and your pH. We talked about the fact that back in chapter 16, the kidneys make erythropoietin to help you up your hematocrit, and they make renin to help you regulate your blood pressure. We talked back in chapter 5 about the fact that your skin and your liver and your kidneys help you make vitamin D so you can absorb calcium. And then sort of alluded to in previous chapters about metabolism, if you're starving to death or if you have not eaten for a considerable period of time, your kidneys can help convert proteins and lipids to glucose. That's gluconeogenesis. And so they can help you regulate your blood sugar level a little bit as well. So this gets you your anatomy of the urinary system. Most people have two kidneys, a right one and a left one. The right one tends to be a little bit lower. The liver takes a lot of room up here, so it's just a little bit lower than the left one happens to be. Sitting on top of each kidney, you have the adrenal glands, which aren't part of this system, but they're sitting here, so we might as well go ahead and get those labeled again. We've got renal arteries that take blood into the kidneys so we can filter waste out of that blood, and then renal veins that drain the blood from the kidneys. We've got two ureters, one for each kidney. They take urine formed from the kidneys down to the urinary bladder, which can store the urine and then release it through the urethra whenever you are willing, I guess, to release said urine. So that's your anatomy of the urinary system. Next up, you have what are the three layers of supportive tissue around each kidney. So I'm going to start at the outside and work my way in. First off, you have the renal fascia, which is this brown layer going on in this picture. So that's just a nice little sheet of connective tissue that helps to anchor the kidneys in place. Deep to that, you have just a layer of adipose tissue, or what the book is calling the perirenal fat capsule. They help to insulate the kidneys, protect the kidneys, and hold the kidneys in place. The fibrous capsule, not quite sure what color you'd call that, beige, but it's the layer that is directly outside of each kidney. Another thing that sucks about you guys not being able to go to lab is you don't get to dissect your kidney, but the only part of these layers that were still present on the kidneys you were going to dissect was the fibrous capsule right there. I'm just going to skip past these. So, one of the things that can happen if a person loses a lot of weight very quickly is that perirenal fat capsule can actually decrease in size. And so you lose that anchoring function that layer had done, and so the kidney can actually slip out of position. That's what ptosis is. The P is silent, you just say ptosis. If the kidney slips too far, one of the side effects that can happen is it will actually kink the ureter so that the urine being formed in the kidneys can no longer be drained down in the urinary bladder. And so that urine starts to back up into the kidneys. That's what hydronephrosis is. It means your kidneys are essentially drowning in the urine they're creating because there's no exit path for that urine to take anymore. This usually has to be replaced or repaired with surgery, get the kidney back up into place, unkink that hose, or they can shorten the ureter so that they can end up draining appropriately like they're supposed to. Next up, you have this picture of the basic anatomy of the kidney. So you have that capsule that goes around it, which again would have been on it had you guys been able to dissect it. Next up, the kidney is divided into the cortex, which is all of this layer out here, and then the medulla. The medulla has all of these little triangular regions. Each one of those is called a renal pyramid. So this is a renal pyramid, that is a renal pyramid. In between the renal pyramids, you have renal columns. Next, there's going to be these little structures that are called nephrons. The nephrons are they start kind of up here in the cortex, but they come down, and then there's a collecting duct that ends up dripping the newly formed urine into this little structure, which is called a minor calyx. Calyces is plural. So this is a minor calyx, that's a minor calyx, both of them together, minor calyces. The minor calyces merge together to make a major calyx. So here's a major calyx, here's a major calyx, here's a major calyx. The major calyces merge together to make the renal pelvis, which is kind of this swollen end going on right here, which is eventually going to taper off and then become the ureter that's going to take that urine down to the urinary bladder. So that's the basic anatomy that you have within each kidney. Next up, pyelitis, infection of that renal pelvis that we were talking about just a second ago. If the infection is localized in that region, the kidney is usually still functioning okay, but you're still going to have problems excreting your urine just because of the inflammation that's in that area is preventing the urine from actually going towards the ureters. This can also back up into that hydronephrosis we had talked about earlier. Pyelonephritis means the whole kidney is involved at this point, which is what's going on in this picture. You can actually see pus that's forming in the renal cortex. The renal columns have essentially disintegrated because of the bacterial infection that was happening in this case. Here on this picture, you can see these little arrows are pointing to areas where infection has caused a lot of inflammation within the renal pelvis. And so this one is showing you the pyelitis. This one is showing you the pyelonephritis. Next, we're going to start talking about how the kidneys actually do their job, and the functional unit of the kidney is called a nephron. So the nephron is the part that filters the waste out of the blood and then starts the process of making urine. This is one nephron right here, and each kidney is made out of about 1 million nephrons. So there's a bunch of these in each kidney. The nephron starts with part of the circulatory system. It's this little ball of capillaries. It's called a glomerulus. So blood is going to come in through an afferent arteriole into the glomerulus, and then blood's going to drain from that in an efferent arteriole. Because of a little quirk where the efferent arteriole is smaller than the afferent, then what's going to happen is we're going to build up blood pressure within the glomerulus, and that blood pressure is going to start forcing plasma out, and then this cup is going to catch it. That cup has different names. It's either the Bowman's capsule or the glomerular capsule. I think your book calls it glomerular, but I think your lab manual calls it Bowman's. I don't remember for sure what your lab manual calls it. But that cup starts the process of changing, filtering, creating that urine. From there, the Bowman's capsule starts to make this renal tubule, and that renal tubule is going to modify what's in the urine and what we put back into the bloodstream. So, renal tubule, it's all that part that I was just talking about. There's several different parts to it. There's the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and then that goes to a collecting duct. You can see like there's nubs coming off the collecting duct. There would have been another distal convoluted tubule to another nephron attaching there and another one there. So again, there's a bunch of nephrons. They're just showing you one in this picture. The renal corpuscle is the glomerulus, the red capillary ball, and the Bowman's capsule all put together. So its entire structure is the renal corpuscle. Filtrate. I like to call it pre-urine. You make a lot of filtrate every day. I want to say that your book says you make like 200 liters of it every day. You don't pee 200 liters every day. So you make a lot of filtrate, but you're going to be putting most of that back into the bloodstream so that you can maintain your blood pressure while still getting rid of the waste that you're supposed to. So I'm showing you this, well, it says platelets, but this is a lot of plasma and platelets that are inside of that plasma. Filtrate is essentially plasma. If you remember, the name for fluid changes depending on where you are. So if like you're in between the cells, it's interstitial fluid. If it's in a lymph vessel, it's called lymph. If it's in a blood vessel, it's called plasma. Well, if that fluid is in the renal tubule, it's called filtrate. Next up, podocytes help control how much filtrate you end up producing. Like if you start to get really dehydrated, your blood pressure starts to drop, and the podocyte actually wraps tighter around the capillaries, so less of the plasma will leak out. Because if you're getting dehydrated, you don't really want to make a whole bunch of filtrate and try to make a bunch of urine, because that will kill you that much faster. If you have had a bunch to drink, they relax their grip a little bit so that you can filter out more of that fluid. So these just kind of regulate how fast you're creating the filtrate. Next up, I gave you a picture of a nephron to go ahead and label. We're going to add some to it, but once again, go ahead and pause the video so you can at least get these labels on there. Okay, so here's what we need to add to this picture. There's a blood vessel that takes blood into a glomerulus and a blood vessel that takes blood away from the glomerulus. The one that goes in is bigger, so label this one the afferent arteriole. Then label the smaller one the efferent arteriole. So the analogy that I usually like to give as I'm discussing what's going on here is imagine that you're driving on a 5-lane highway and then there's a wreck. And they close 4 of the lanes. So we had 5 lanes taking blood in here, but we only have 1 lane that's trying to take the blood out. Well, what happens when they close that many lanes on a highway? 2 things. We get a backup, and then people start driving over right of ways and start taking exits just to get out of that backup, the same thing happens here. So blood pressure builds up within the glomerulus, and then plasma just starts leaking out because screw it, it doesn't want to wait in that line, so it goes ahead and it fills into the Bowman's capsule that's outside of that. And so because the efferent arteriole is smaller than the afferent, we start that process of filtration to create the filtrate there in the Bowman's capsule. So that helped us get those labels down: afferent blood in, efferent blood out. Some other things that are going to be helpful. Wrapping around the renal tubule, we're going to have a fair amount of blood vessels called peritubular capillaries. Those are going to play a very important role in two processes. One is called reabsorption, another is called secretion. We'll talk about those more here in just a little bit. The juxtaglomerular apparatus is these gray cells, essentially, that are forming right in this region. What happens is a portion of the renal tubule wraps back around between the afferent and the efferent arteriole, and it's sort of detecting blood pressure, and then we're also detecting what's in the urine to make sure we're getting rid of everything that we're supposed to while also regulating blood pressure at the same time. So it's just a way for us to maintain that homeostasis and make sure we're doing everything we need to be doing while not dropping blood pressure too much. Next, describe the filtration membrane functions and its components. So I started with components up there at the top. Kind of like when we were talking about the respiratory membrane, we've got three layers here: the capillary endothelium, the glomerular capsular Bowman's capsule layer, and then the basement membrane that glues those two things together. Just like the respiratory membrane was trying to allow for diffusion, so is this one. So we've made this as thin as we possibly can, simple squamous epithelial tissue, and usually either simple squamous or simple cuboidal epithelial tissue when you start talking about the kidney portion of this, the glomerular capsule filtration slits going on up here. What this does is it allows for most of the plasma to leak out, but it's going to keep the cells in the bloodstream. It's going to keep the really large proteins in the bloodstream. So it's a selectively permeable membrane to allow us to get rid of the stuff we need to while keeping the good stuff hopefully behind. Okay, so here's where I'm going to attempt to doodle. And I don't remember if I've doodled with you guys on PowerPoint before, but it does not usually turn out super pretty as I do it. But here we go. We're going to draw a very abbreviated little nephron. So we're going to have, oh, you son of a biscuit. Apparently I'm going to cuss a fair amount as we go through here. All right, let's try that again. So we're going to have, why are you clicking? If it doesn't work this time, I'm going to give up. Okay, so we're going to have the afferent arteriole that's bringing blood into the glomerulus. And then we're going to have the efferent skinnier arteriole that's bringing the blood in. Okay. Now, what's going to happen, I don't know why I just clicked on that. I was trying to click on this. Oh, I hope you guys are laughing at my ineptitude at this point. Let's see, I'm going to do this in yellow. Okay. Because of that blood pressure phenomena that I was talking about earlier, what's going to happen is a lot of that plasma is going to start to leak out, and this little cup is going to catch it. So the cup is the Bowman's capsule. So Bowman's capsule. The red knot of squiggly lines is the glomerulus. So the very first thing that happens in here is called, why aren't you going? There we go. Filtration. Happens here in this first part that I have doodled. And what happens in filtration is, because of the increase in blood pressure within the glomerulus, the plasma leaks out, and then it fills this renal tubule. That process of filtration is what creates filtrate. And we're going to stay as filtrate or pre-urine as we go through here until we get done with the third and final step. Okay, I'm going to switch colors again. Or at least I'm going to try to, if my technology will agree with me for just like half a second. Next thing that happens, because filtration is not super selective, we put a bunch of fluid off into the filtrate, and we cannot have all that fluid stay there. Some of it needs to go back into circulation. So I'm going to doodle a blood vessel, those peritubular capillaries that I was talking about earlier up here. What's going to happen is what's known as reabsorption. Some of that fluid that had come in here is going to go back into the bloodstream so that we can keep the blood pressure where the blood pressure needs to be. Also, there were some things that we filtered, like amino acids, that we don't actually want to get rid of. So we can reabsorb those back into the bloodstream. So what I like to say reabsorption is us putting the good stuff back into blood because we don't want to get rid of it. Reabsorption can be either passive or active. It depends on what you're moving, when you're moving it, how you're moving it. There's a bunch of different features that come into play there. Okay, one more process. And I'll do this one in purple. There are some things that are left behind in the blood or that you reabsorbed into the blood that you didn't really want to keep in your bloodstream. And I'll use like Tylenol as an example, or any drug really. Maybe that drug didn't get filtered out to begin with, and so it's still in the bloodstream. Well, what will happen in the third and final step is we'll take the bad stuff that we really want to get rid of from the bloodstream, and we will actively pump it into the renal tubule. That is called secretion. So there are 3 different steps that help you form your urine: filtration, reabsorption, and secretion. Filtration happens because of a blood pressure phenomenon. Reabsorption is about diffusion and osmosis, and there is active transport that happens there too. And then secretion is fully an active process where your body is actively trying to get rid of bad stuff that got left behind. Okay, here are those things in the notes so that you can again make sure you have that stuff written down, pause it if you need it. Next, what are some factors that influence or regulate glomerular filtration is the next thing that you have in the notes. And I guess I forgot I had this slide coming up. But this is your book's representation of what I had doodled earlier. Clearly much cleaner and prettier. But up here within the renal corpuscle, we have the blood pressure forcing most of the liquid in the blood out into the glomerular capsule, creating filtrate. That process is called filtration. The good stuff that we filtered out that we didn't really want to, we put it back into the peritubular capillaries. That's reabsorption. And anything that we reabsorbed that we didn't want or we didn't filter out that we needed to, we actively pumped that back into what's going to be urine at the end of the third step. So after we've done filtration, reabsorption, and secretion, it's not filtrate anymore. At that point, it's called urine. Okay, so factors that influence glomerular filtration is what we had next. Now, this is the picture that I'm going to be referring to as we talk about these things. First off, the number one thing that impacts how high a filtration rate you have is the blood pressure within the glomerulus itself. You can regulate that by vasoconstricting or vasodilating the efferent arteriole, but your overall blood pressure also is going to play a role there. The higher the blood pressure is, the more filtrate person is going to end up secreting, and vice versa. Next, capsular hydrostatic pressure. There's already filtrate in the Bowman's capsule. That filtrate is trying to prevent more fluid from coming in here, and so that is trying to counteract that blood pressure that you've got going on. Third and final thing is because most of your plasma has left the bloodstream to create filtrate, that means the blood that's still in the blood vessels is very thick. If you remember, what that does is it creates a concentration gradient that's going to want to suck water back into it. And so that's what blood colloid osmotic pressure is. It's because the blood is very thick, it wants to absorb water back in. And so this is also trying to counteract filtration. Now your book gives you some numbers here. If you do the math on all of these, what it essentially amounts to is 30 plus 15 is 45 millimeters of mercury are trying to counteract blood pressure. But the blood pressure is 55 millimeters of mercury, so we end up with about 10 I don't know why I can't talk all of a sudden, millimeters of mercury that's still forcing filtrate from the bloodstream into the renal tubule. Next, anuria is the inability to produce urine. Your book defines it as a person has less than 50 milliliters per day of urine formation. What this amounts to is the kidneys aren't filtering like they're supposed to, so there's a problem that's happening. Okay, reabsorption, I mentioned earlier, can be passive or active. Your book spends a lot of time talking about the different things that can be reabsorbed either actively or passively, and I really don't want to get into all that much detail with you. We just don't have time for it. So what I'm going to boil this down to is active processes means you have to spend energy to do it. Passive processes mean you don't. And so passive processes just rely on diffusion and osmosis. Tubular secretion. This is where we had our last ditch effort to get bad stuff out of the bloodstream and put it off over into the urine that's going to be formed, and this is some other stuff that it's doing. So it does help you get rid of excess potassium ions. We have talked before about hyperkalemia and that it can make your nerves not fire like they're supposed to, and so it can kill you if you have too much potassium in your body. It does also help permanently remove either acids or bases from the body, depending on what your body needs to happen at any time. Diuretics. We've already talked about these numerous times. They make you pee more. They do that by either increasing your filtration rate so you make more filtrate, which can be tied to you will make more urine, or they are going to decrease the amount of reabsorption that happens so that you're not putting most of the stuff back into bloodstream. It stays in the urine. And so different diuretics work in different ways. I actually have to click out of that momentarily, a little hyperlink to show you an overview of what we've been talking about and how some diuretics are going to work on this system.
As everyone knows, we have two kidneys, each functioning independently. Diuretic action occurs in the kidney. This is where the body controls filtration, reabsorption, and excretion of water, small molecules, and ions, such as sodium and potassium. The outer layer of the kidney is called the cortex. The inner layer is the medulla. This is where we have millions of special structures called nephrons. We'll now zoom in to a single nephron. Nephron is a tubular structure similar to a porous pipe or hose. The glomerulus serves as a starting point for the flow through the nephron. First, the blood enters the glomerulus through the afferent arteriole. The blood exits the glomerulus through the efferent arteriole. The glomerulus is where the blood supply is filtered by osmosis and diffusion. As blood passes through the porous capillary loops, water and molecules smaller than about 50,000 molecular weight are filtered, passing into the Bowman space. This creates the luminal fluid flowing through the nephron tubula. About 1/5 of the total blood volume is continually filtered into the Bowman's capsule. About 99% of this volume is reabsorbed, leaving only a small volume to be excreted as urine. Each section of the nephron has a different morphology of cells making up the single-cell wall, which causes differences in water permeability and ion transport. The first section of the nephron is called the proximal convoluted tubule. The proximal convoluted tubule is highly permeable, and about 65% of the filtered sodium and water leak out to be reabsorbed into the nearby capillaries. Old diuretics called carbonic anhydrase inhibitors mostly act on this portion of the nephron. The proximal convoluted tubule leads into the loop of Henle, which has a thin descending limb and a thin and thick ascending limb. The thick ascending limb normally reabsorbs about 25% of the filtered sodium, but does not allow water to reabsorb. The loop diuretics act here by blocking sodium-potassium chloride ion cotransporters on the luminal membrane. The next section is called the distal convoluted tubule. This section does not allow water to reabsorb, but reabsorbs sodium through the sodium chloride ion cotransporters. The thiazide diuretics act here on this transporter. The last section of the nephron is called the collecting tubule. Sodium channel blockers and aldosterone antagonist diuretics act here.
Alright, I'm not going to get into the molecules that he starts talking about, but that was a decent overview of everything that we had been talking about so far. Next up. Chronic renal disease means that your kidneys are chronically not doing what they're supposed to be doing. And so your filtration rate is crazy low because your kidneys just can't do that anymore. What that means is the waste is going to accumulate in your bloodstream. And because usually what your kidneys do is get rid of excess acids, since they're not doing their job anymore, you're going to build up those excess acids and your pH is going to drop as a result. Now this picture is actually from Costa Rica. They were having an epidemic in their sugarcane workers where almost all of them had chronic renal disease. And it ended up being tied to the fact that they were constantly dehydrated. They didn't drink as they were going out and they were harvesting their sugar canes. Instead, they would just take a piece of the sugar cane and put it in their mouth, and it helped them not feel thirsty, but it didn't actually replenish any of the fluids they lost during the course of the day. And so a lot of adult men in this small town ended up dying, all because they were constantly dehydrated and their kidneys could not filter anymore. And so this is my warning to you guys. Make sure you're drinking plenty in Texas in the summertime, or bad things happen to your kidneys. Renal failure is what ends up resulting from chronic renal disease. So again, kidneys just not doing their job anymore, waste builds up. If this is a problem in a person, then that means we have to filter that waste for them. So we'll do hemodialysis, which, like I say here, most people just call it dialysis. We hook you up to a machine, and the machine does the filtering for you. Now, I found this video a while back. The backstory on this video, if it is going to play, since they did develop new algorithms, YouTube did. Let's see. Good. The story for this little girl, and I'll kind of show it to you off over here, she was getting bullied because you could see her lines in her neck. And so the mom made a video to show everybody in the class, like, why did she have those lines, in the hopes that it would stop them. Kids are just dicks, essentially. But here is this little girl explaining how dialysis works so kids would stop being mean to her.
This is what I do at dialysis. First, I make sure that my shoes are off, and then I go over to the scale.
You're a star today?
Yeah. That was Jennifer. And today's weight is 19.5. 19.5.
Alrighty, I got it. Thank you.
And then I took my temperature.
There's the temperature. What's the thermometer?
Big one here.
And does anybody help you do this, Danielle, or you do it all by yourself?
No, I take my weight all by myself and my temperature.
And is that good or is that bad?
Good.
Okay.
Alright. There's the blue thing is the button that you push it in. Oh, and it makes the little
Cover?
plastic
Okay.
fall.
And now what happens?
I need 2 thumbs for this.
Oh, good job.
Okay. And now what happens, Danielle?
And then take my blood, and then they take my blood pressure, and then take a little bit of blood from my lines, and then they start checking my lines.
What is your line? Can you tell us? Because a lot of people probably don't know.
Well, it's my catheter, and it starts here, and it goes in right here.
Oh, okay. And what does it help you do?
Well, what they do is they hook me up to that machine right there,
This big thing, huh?
and they say it's my robo-kidney.
All right, I'm going to pause there for just a second. Like, that's the perfect description of what dialysis is. That machine is now acting as your kidney, so it's kind of a robo-kidney. They're going to spend a lot of time cleaning her lines out because they do have direct access to her blood supply. They've got to make sure that they keep them very clean to the point of sterility. Otherwise, infection can set in and lead to sepsis, and they don't want that to happen. I'm going to skip to right here. And I know this is going to look really blurry and kind of difficult to read, but what I want you to notice is she has to be hooked up to this machine for 3 hours. But in the span of those 3 hours, this machine filters her blood enough to last her for several days. So the machine is more efficient than the kidneys, but that's because we can't have you hooked up to a machine 24/7 where your kidneys do work 24/7. And so that's dialysis. We hook you up to that machine. That machine does all the work of your kidneys, but it does it better. It does it so much better, in fact, that it's actually, in some cases, detrimental because it can do things like remove hormones from your bloodstream that you didn't want removed. And so a lot of times people on dialysis will develop subsequent anemia because they're not making their EPO, and because some of their other hormones are getting filtered out too, they end up having to put on those hormones in excess of what would be normal because their kidneys are essentially broken. Okay. Describe normal urine in terms of color, transparency, odor, pH, and specific gravity. You've seen urine, you know this stuff up here. pH, your book says 4.5 to 8. 4 to 8 is perfectly fine for me though. Specific gravity tells you how concentrated or dilute a solution is. For example, water, pure water has a specific gravity of 1.00000. So urine should be a little bit more concentrated than that, but not crazy concentrated. So 1.001 to 1.035 is where your urine should be. Reference values. Blood should not be in your urine unless you are a menstruating female, in which case there is blood in the urine once a month. That is normal. However, if you are getting blood in your urine at other times, that tends to mean that you have an infection someplace in the urinary system. Osmolality is another measure that tells you how concentrated or dilute something is. We actually talked about that last semester when we were talking about how do you calculate molarity. But your urine should be either really low because you're well hydrated to fairly high because you're starting to get dehydrated, but within this range it's considered to be normal. If the number gets to be too high, that means your urine is getting to be super concentrated, so you might end up with too much sodium in the bloodstream. That might mean you have congestive heart failure, and it can indicate acidosis eventually as well. If the number is too low, you might have diabetes insipidus. Remember, that's a problem with ADH, or maybe you've just been drinking way too much water way too fast. Protein, really shouldn't have a bunch of protein in your urine, so it should be less than 8 milligrams per deciliter. If it's high, it tends to mean infection, but it can indicate some other problems too. We already talked about specific gravity. The notes are the same as for osmolality up there. pH, most Americans have a pH somewhere around 6-ish for their urine, but again, it can vary within this range. If it's low, it might mean you just have too many acids in your diet, like maybe too much coffee, too many soft drinks, things like that. If it's high, it usually means you have an infection, but vegans can make it high too because of the proteins that they're consuming. This is another thing that you guys don't get to do since you don't get to go to lab, but usually we have you do urinalysis, and essentially you pee in a cup, we dip a stick in the urine, and then we go through and we read what are the values on those sticks by just comparing what's the color on the stick, and is it this color, which means your specific gravity is 1.020, which is still within normal range, but it does mean you're starting to get a little bit more concentrated, and maybe it's time for you to start thinking about drinking something. The blood thing, remember most people, especially for guys, if there's blood in a dude's urine, it's a problem every time. But for women, once a month, for several days, we get blood in our urine, and so it's not necessarily a problem. So don't jump automatically to, oh my god, this person's dying, because sometimes there's reasons why you might find this in their urine. You need to ask some more questions about it. Should glucose be in the urine? No, your body should be reabsorbing any glucose because it is a nutrient that you want to keep in your body. If there is glucose in the urine, tends to mean one of two things have happened. Either the person just consumed a whole bunch of carbohydrates, or they have, diabetes that is not being properly maintained. There are 3 different forms of nitrogenous waste that you can find in your urine. We have already talked about urea before. That's on this side off over here. Remember, you have to deaminate an amino acid to use it during cellular respiration. That amino group from the amino acid gets converted to ammonia, then urea, so this is the protein part, essentially. We talked about uric acid last semester when we were talking about gout. So gout was a buildup of uric acid crystals in the joints. Remember gouty arthritis? This is the result of eating like too much red meat. It really comes from the breakdown of nucleotides, but too much red meat is going to have a bunch of nucleotides in it too. And so you can build up this uric acid, but ordinarily your kidneys put this into the urine so that you're peeing that out along with everything else. Your last option is creatinine. So there should be some of this in your urine as well. Moving away from the kidneys, next step, ureters. Again, take the urine from the kidneys to the urinary bladder. Renal calculi are kidney stones. The ureters is where they tend to get stuck and cause lots and lots of pain. I wanted to show you just what a kidney stone looks like when you blow it up under a microscope. So imagine this scraping through really narrow tubes in your body, and that's why it hurts so bad when you get kidney stones. They have really sharp little edges to them. This just shows you where a person tends to hurt whenever they have kidney stones. Usually you just kind of have to pee them out, and it usually super sucks when you're peeing them out, but after it's gone, you just want to make sure you drink more. The more often you get dehydrated, the more likely you are to form kidney stones, but there are a couple of other reasons why they might form as well. Urinary bladder, again, stores the urine and then releases it whenever your body has deemed it appropriate to release that. What are some of the modifications that it has? Well, it has rugae, kind of like the stomach does. Remember, the rugae were the folds that allowed it to be really expandable. It also has transitional epithelium, which we talked about last semester. That was one of our stretchier types of epithelial tissue, and so that's how the stomach gets modified so that it can do its job. It can stretch and still contract so that you can push the urine out after it's stretched because it has a layer of smooth muscle that helps to make it up. The urethra is going to drain urine from the urinary bladder to the outside world. I'm showing you the difference between female and male urethras, which is going to come back to us a little bit later on. In men, the urethra does also play a role in the reproductive system. In women, it does not. At least it should not, although there are weird stories out there, but it should not play a role in reproduction for women. But sperm and urine both exit through the urethra in men. Sphincters. There are two sphincters that control when urine gets released from the urinary bladder. The internal sphincter is smooth muscle. It's involuntary. It relaxes whenever your bladder gets somewhere between a quarter to a half full. You can't do anything about that. It just opens. The external sphincter, you do have voluntary control over those, so you can hold that one until you are ready to release said urine. A couple of little side notes about that. The reason why babies are always incontinent is because they have not yet learned how to control the external urethral sphincter. So they just pee whenever the internal sphincter opens up because they can't control this one just yet. One of the other consequences is as you get older, especially for women, the external sphincter gets weaker and it becomes more difficult to hold your urine. And so that's why many elderly women end up having to wear adult diapers. It's because they start to suffer from incontinence again because they can't control that sphincter very well anymore. Another quirk of the male system is between the bladder and the outside of the body, they have a prostate gland, which is sort of this little donut-shaped yellow thing going on right here. The urethra goes right through the middle of the prostate gland, so the urethra within that gland is called the prostatic urethra. One of the reasons why this is medically relevant is because where women tend to get incontinent as we get older, men tend to get enlarged prostates as they get older, and that makes it more difficult for them to urinate because the swelling in the prostate essentially kinks the urethra and makes it more difficult for the urine to actually leave the body. Now, here's where we're going to come back to some of the differences. First thing I want you to notice is the length is obviously different in men versus women. Men have a much longer urethra because it has to go the entire length of the penis, which women just don't have. So ours is shorter. The consequences of that shortness are women will get more urinary tract infections than men because it's a lot easier for bacteria to travel this far than it is for bacteria to travel all the way up there. And so men are just less likely to get those infections. There's also hygiene issues that go along with that in terms of wiping, and men don't have to wipe every time they go to the bathroom. And so that's another issue that plays a role in urinary tract infections, or UTIs for short. Now, I'm going to come back to that length thing again a little bit later on. Let's see, next thing we need to talk about. Urethritis is inflammation of the urethra and cystitis is inflammation of the bladder. Both of these would just be called UTIs for urinary tract infections. It's really easy for bacteria to travel from the urethra to the bladder, and so a lot of times the infection is basically all through there. If the infection lasts long enough, it can even travel up the ureters and get to the kidneys and cause that pyelitis and pyelonephritis that we talked about earlier. So if you ever have any difficulty urinating, like it burns when you pee or you're just having trouble peeing, you should go seek treatment because if you let it keep going, you're going to have more problems later on. Dysuria is painful urination, like usually it burns when it pees. Micturition is the act of peeing. Incontinence means you can't not pee when you don't want to pee, so you're incontinent. You're just peeing when you didn't want to. Urinary retention. This is an inability to void your urine. This is more common in men, and it tends to relate to that benign prostatic hyperplasia that I alluded to earlier, where the prostate gland gets enlarged in men. There's a story in one of the books that I usually give you guys. Unfortunately, it's stuck in my office, and we're not allowed to go on campus to get it, but it's from Every Patient Tells a Story. And in that book, they talk about a man who presents into either a clinic or an ER. I have forgotten which one he presented to. But he has all the symptoms of a stroke, and they start doing a stroke workup on him, and it turns out there's no neurological problems in terms of lesions. Like his blood flow is going through the brain just fine. And after them trying to figure out for a while what was wrong with him, they finally realized nobody inserted a catheter like they were supposed to. He hadn't peed in a significant period of time. His bladder held, I want to say they said it was like 2 gallons. It was an insane amount of urine that was inside of there. When your bladder is holding that much, that means urine is going to stop draining from the kidneys into the bladder, and you can get that hydronephrosis that I was talking about earlier. So he had stroke-like symptoms all because he couldn't pee because his prostate gland was inflamed. And if they had just inserted the catheter at the beginning, all of his symptoms would have gone away. And so it's an interesting little story in that book. If you hadn't figured out what book you want to read for extra credit, Every Patient Tells a Story is a really good book that most of my students really like to read. In fact, I've never heard a student tell me they didn't like reading it. Okay, so I said I was going to come back to the length thing. This is where I'm coming back to the length thing. So this is a Foley cath. Foley caths get inserted like pre-surgery, or if you have a person who's incontinent all the time and they can't move around all that much, you give them catheters. There's different sizes of catheters depending on who you're catheterizing, how many times they've been catheterized, a whole bunch of factors. This is what a catheter looks like when you're in the act of putting it in, although this one also is missing something because this is for self-catheterization, but I'll talk about that in a second. First off, you maintain a sterile field because you don't want to stick something with bacteria into a person's urethra. That's going to set up a urinary tract infection, which in a person who needs a catheter, there's other problems at play, so we don't want to do that. So we insert it up the urethra. Once we have it inserted up the urethra, then we insert air into it to inflate this little balloon that's at the end so that the catheter stays in the urinary bladder. This bulb is in the urinary bladder, and then the rest of this tube is draining out the urethra. And then there's a bag attached at this side to collect the urine. Okay. Here's what's important. When you insert this, for a woman, you're only going to insert it up a couple of inches because her urethra is really small. For a guy, you have to insert it up several more inches because their urethra is just longer. If you screw this up and you only insert it a couple of inches and then try to inflate a balloon in their penis, how happy do you think that patient is going to be with you? Not very happy. And so you got to make sure you insert it the correct length depending on the length of that particular gentleman's penis, because everybody's penis is a little bit different. You have to consider that in there as well. Now, here's the other little sad, weird story that I will give you that relates back to this. There's something about men where when they come out of surgery, their first thought is, I should check out my penis and make sure it's still there. And when they do that, they will notice they have a tube sticking out of their penis. And now their second thought is, well, I should pull that out. And if they try to pull it out, they are pulling an inflated balloon through their prostate gland and then their penis, and that is never a good thing to do. And so if you are working in a ward where people who have recently had surgery are coming out of anesthesia, keep an eye on their hands and make sure you know where their hands are so that they don't pull this out, because they get it out a little ways and then they realize, oh crap, that was a mistake and I shouldn't have done that. So just be on the lookout for where their hands are as they're coming out of stuff. After that, you just have your related clinical terms and then your Latin roots. I'm going to be uploading a coloring quiz for you guys so that you can learn more about your nephron anatomy and stuff. As you complete that quiz, make sure you don't skip number 7. I don't know what it is about number 7. Everybody always just skips that question, and you miss it if you skip it, so make sure you circle an answer on that one.